Hello and welcome to Gastro Learning Live. I'm George Webster and absolutely delighted to welcome Professor Evelien Dekker from Amsterdam to join me this afternoon. My main focus endoscopically is HPB, and I don't think we've ever had an endoscopy paper that has raised as much interest as in colonoscopy, and particularly the NordICC study just published in the New England Journal of Medicine. Evelien is not only a world authority on all things colonoscopy and colonoscopy screening, but was also part of this study. So Evelien, it's an enormous pleasure to have you with us. We're not going to just talk about the NordICC study, but that's obviously the main focus. Give us an overview. Why is this an important study, and why is everybody getting perhaps slightly animated about it?
Yes. Hi, George. Very happy to be here with you. Happy to join in. So indeed, the NordICC study was published last week, and it is the first randomized trial ever published on a group of individuals, an average risk individual group, undergoing colonoscopy screening or being invited for colonoscopy screening as opposed to no screening. So up to date, only cohort studies were published, so we could guess about an average protective effect from colonoscopy in a screening population. And this is the first study that shows a randomized design. Why it does raise a lot of attention is that the effect in this study after 10 years of the intention to screen analysis, so for those being invited for colonoscopy screening as opposed to the control group, was not as big as expected. So after 10 years, the incidence rate for colorectal cancer was reduced by 18%, and mortality rate was not significantly reduced. So there's many aspects we can discuss about, but of course this has made a lot of created a lot of discussion on the size effects of colonoscopy screening.
Okay, and you know, this study was done across I think the 3 countries in Northern Europe. I mean,
originally 4.
Sorry,
originally 4. So 4 countries united in performing this study, which were Norway, Poland, contributing by far the most colonoscopies, Sweden some, and also we as the Dutch participated in the trial. However, for this analysis after 10 years, we had much trouble by the new privacy law in the Netherlands to obtain the information on the control arm. So for now, the Dutch data are not included. So that leaves 3 countries.
Very interesting. Very interesting. And there were differences between those 3 countries in uptake. One of the topics that we're going to go on to discuss is intention to screen, because there were big differences between the 3 countries in the percentage of patients invited to colonoscopy who attended for colonoscopy.
Absolutely. So the issue in screening in general is, of course, participation rates, which are very much of importance in having an effect. So whereas usually as endoscopists or gastroenterologists, we're used to patients coming to our office and asking for examinations, this is not the case in an average risk population. So usually the effect of a screening program is being evaluated by the effect in the total population being invited. So you have to, that results in a very large effect of the actual participation rate. The other way you can look at screening and is saying, well, once the patient or the individual, healthy individual, is willing to undergo screening, what will be the effect of colonoscopy? That's another way. So the first is an intention to screen analysis, and in the second case, it's a per protocol analysis. And as indeed participation rates for colonoscopy, primary colonoscopy screening, vary widely, the effect is definitely different in the two groups. So in between the countries, indeed, in Poland, only 30% of the invitees did actually accept the invitation and undergo a colonoscopy, whereas in Norway, this percentage was over 60%, which reflects, I think, many cultural differences. We know from the Nordic countries that usually patients are more obedient, more obedient to their doctors or their ministry or many other things. That's well known from studies. And the question also raises then who does participate, right? So if participation
before we get on to that, clearly intention to treat is the, shall we say, the purest and most correct way of expressing, of doing the study and expressing the results. Do you think in this case that has led to a confusing interpretation? If we step back and look at the per protocol data, it looks much better. Is that fair to say? In other words, the people who actually are screened, when we look at their data, it moves us much more towards the sort of results that we would have hoped for with colonoscopy screening.
That's absolutely true. And it's exactly as you say. You can debate which one is more useful. However, in colorectal cancer screening, we very much stress the fact that screening is important only be effective if people participate. And indeed, if you are in a country where everybody that you invite will be willing to undergo colonoscopy 100%, you can use a per protocol analysis, but that's not the case. So for interpreting these data, you should indeed, for your own situation, your own country or your own practice, know how much your participation rate would be. On the other hand, I also think it's unfair to do a per protocol analysis because that's not the way screening programs are designed. And we know in many countries, primary colonoscopy screening suffers from low participation rates.
And do we, we know that colorectal cancer does not affect all socioeconomic groups, all patient types equally. Does that have a relevance if we are talking about intention to screen, in our practice, never mind in this study?
Definitely, although it will be relatively difficult to unravel, but for sure, when there's low participation rates, the population that is participating might be biased. There might be a healthy screen bias, meaning that people that are very health conscious and aware that screening is available, have the ways of getting to their doctors, might be willing to pay something extra to undergo that if needed. They might be screened more easily than people from lower socioeconomic classes, which in themselves, as you say, might have a higher risk. On the other hand, it might also be used for people or by people that have symptoms and that see their family doctor, and the family doctor, I don't know, but if you participate in screening, we will know. So it might end up being relevant in both ways, although I think the healthy screen bias is a more logical one to consider in general. So yes, there will definitely be influence there. And that's exactly why in many European countries, screening by another method that's less invasive, less expensive, and more accessible is favored.
Can we come back to that in a little bit, because
Sure.
I think that's, you know, in many ways the sort of, you know, a really central discussion from this data. Getting back to the data, certainly in the UK screening program, when it was introduced, you know, 10 or more years ago, more than that, 15 years ago.
Because I was there when it just had started.
Oh, well, I'm really showing my age. But one of the, even now, the two parameters that are seen as markers, certainly were at the beginning, markers of good quality colonoscopy, was cecal intubation rate and adenoma detection rate. Now, when the screening program started, nobody even talked about sessile serrated lesions, for example. But what comment would you make about cecal intubation rate, complication rate, and adenoma detection rate in this study?
Yeah, so indeed, some of the quality parameters were displayed also in the publication, right? I know you've prepared some slides.
I think we might be able to show that.
We have data for the several countries on both adenoma detection rates as well as cecal intubation rates. And there's clearly differences between endoscopists and between countries. Yes, what we know now is that, you know, we have set a specific bars for the quality for cecal intubation rates, which should be above 95%. And you can see a few of those endoscopists is lower than that. So yes, there might be a little influence there. The ADRs are, I think, generally quite acceptable. You're probably aware of the studies from Poland, for example, showing that an ADR of 25 probably should be about the bare minimum for an endoscopist, so in a screening population. And you can see most are above that, but a few are lower than that as well. So yes, those parameters vary between countries. And might have had an influence. Yeah.
You know, as you mentioned, this study started, you know, well over 10 years ago, and you know, adenoma detection rates of 20%, 25% at the outset was seen as being, in, you know, a reasonable standard, and you know, most established large screening programs would now not, you know, not accept 20 or 25%.
No.
Is that, you know, just a reflection of how long ago the study was done? Is it a reflection of improved endoscopy, improved equipment? You know, why have we changed what we think is acceptable?
Yeah, so that's an important question. So indeed, I think the introduction of colorectal cancer screening programs, I mean, the UK has really led us here. At that time, in the UK, the quality of endoscopists was evaluated, and we found out that it was published that the cecal intubation rates were less than 60%. So this has really started a big promotion or awareness on quality of colonoscopy. And yes, by time, I think many other countries have adopted parts of such a quality assessment program. Also in my country, we have started that. But at the beginning of this study, this was not yet the case, I think, in any of those countries. So yes, I think also here the study highlights that quality is important, and some people are not there, and you should make them aware, and they should improve. So
you know, but overall, the cecal intubation rate was very good. That there were no perforations in many thousands of patients, all levels of success, and very little bleeding.
Exactly.
But you know, in terms of adenoma detection rate, 35% in Poland, 14% in Sweden. Discussion around that?
Yeah, so I think Sweden indeed is relatively low. I know that in Sweden, the prevalence in general is supposed to be a bit lower. People are very healthy and also having less colorectal cancer. But that's all I can say about this now. So I don't, but clearly there is a large difference, and it might reflect true population differences, although I think the differences are too large to be just population differences. So I think indeed the rates were relatively low, but as you can see, for the total number of patients, Sweden also contributes very little to the total population in this study. So even if important, it's a relatively small part. You mentioned shortly the serrated lesions. That's indeed another factor. I think many older studies have not yet audited or reported on sessile serrated lesions, and I think that's just advancing knowledge on those lesions, that also those lesions may develop into cancer. And I think also that has taken time, and by now many more people are aware that they should look for them. They know how to look for them. And we recently showed in a fit-based population screening program in my country that indeed doctors that are bad detectors for sessile serrated lesions have a higher risk of their patients having PCCRC, so post-colonoscopy colorectal cancer. So, and which is sometimes related to also the ADR, but also independently, it was a risk factor. So this is still fit-based screening and not colonoscopy screening as this study. But I think evidence is accumulating that also SSLs should be detected and probably should also be used as a quality indicator, the detection rate.
So we're going to come on to fit in a minute, but knowledge and expertise and quality measures change over time. Do you think that within colonoscopy quality, we should either be formally adding in sessile serrated lesion detection as one of the quality parameters, and should we be adding that to other parameters, or should we be getting rid of original parameters? Cecal intubation rate here was universally good and wasn't obviously a strong correlate. In other words, as we learn more, are there going to be better correlates of colonoscopy quality, such as post-colonoscopy colorectal cancer and SSL, or are we always going to have to rely on cecal intubation rate, for example?
That's a difficult question, George. I think in the end, of course, what we try to prevent by colonoscopy is cancer, right? So post-colonoscopy cancer would be the ultimate and ideal quality parameter. It's just that both the time and the numbers needed to scope are just far too large to be used for daily practice auditing and monitoring. So we need surrogate parameters that are not as good, but hopefully also good. And I think ADR and proximal serrated polyp detection rate, where you are a bit less reliant on the pathologist because they have an inter-observer variation in their judgment on polyps as well. Are important, and they were shown to be both important and ADR alone did not explain all the variation. If we then need other parameters, they're usually more easy to measure. That's an advantage of cecal intubation rate, if of course still well reported. It's easier than coupling pathology to polyps, right? So it's easier. And actually in my country, when we started quality monitoring in screening, we have started with cecal intubation rates because it was relatively easy. And by using that parameter, we were indeed able to detect some underperformers and try to motivate to do better. So I think it's a quite useful parameter and much more easy to use.
Great. Just got some excellent questions coming in. AI, if one did this study again, is there reason to believe that AI would improve performance? And if so, is that because it's picking up SSLs that we're otherwise missing? Or is it picking up diminutive polyps that we're missing on white light that go on to be associated with cancer?
Yeah, so that's a very nice question. So there's many applications of AI, but clearly this points for now towards AI being used as a detection method, an extra detection method. And up to now, most studies have shown significant increase in small adenomas and diminutive adenomas. And actually just recently, last week at UEG Week, a study from Spain, led by Rodrigo Jover, was demonstrated in a late-breaking abstract session, where the study was properly powered for advanced adenoma detection and the effect of AI. And actually, in that study, advanced adenoma detection rates were not significantly increased by using AI. So I think this is still debatable. Are the polyps that we detect extra indeed in the end that clinically relevant that we need to use AI for that? However, I think AI is an advancement in our endoscopy suite that's definitely going to come and help us. And but we still have to explore how it would support us best. And for example, I think there would be, so apart from detection, we of course know it could help us with characterization, maybe indeed detecting SSLs better. The few data that are around now there might suggest that, but we need much more data because they were not yet specifically trained, the systems usually for SSLs. But it could also, AI could be used to support our quality reporting data, for example. If the endoscope and the system would be able to report themselves if the cecum was reached, if the bowel prep was of good quality, it could help us a lot in making the administrative load of quality reporting, A, less work for us as endoscopists, and B, also be more reliable. So I think in many aspects, AI in the future will support our practice and hopefully might increase indeed the protective effect from colonoscopy. But still, people must be willing to come.
Yeah. So let's move back to that. We discussed it at the beginning. And we all like doing colonoscopy. We think colonoscopy is great, and maybe it is, but if patients don't turn up, colonoscopy can be as good as you like. What about how do you see things developing in terms of other modalities for screening? There's a question about that's come through on the chat about what about FIT and flexible sigmoidoscopy? Maybe talk about FIT and whether, flexible sigmoidoscopy in the UK wasn't quite as promising as we perhaps wanted, but that was before we were marrying it with FIT. Is FIT the future?
Yes, I definitely think a non-invasive test is the future. Indeed, sigmoidoscopy trials have shown a mortality reduction. And actually, it's now debated that the reduction from sigmoidoscopy did seem compared to this colonoscopy screening trial quite good. So the question is whether a full colonoscopy is that much better compared to sigmoidoscopy. However, for example, when the Atkins trial, participation rates were influenced because people were invited first to participate in the trial and then attendance rates or adherence rates were measured. So it was a flawed participation rate. So there's again the issue of intention to screen versus per protocol. Yes, but I definitely think a non-invasive test that selects those people that need colonoscopy best is the way to go. I think it's that's for many reasons. That's for the first of all, of course, for the individual. There's at the moment that you have a test with good accuracy. That's of course crucial. There's a good reason to undergo an invasive test, which is burdensome, has a risk for complications, costs you time and effort. You have to maybe stay away from work. And on societal side, we have to organize workforce. There's cost. So there's so many disadvantages of colonoscopy that it's my very clear view that we need to have good reasons to do such invasive examinations. And I think a non-invasive test is ideal. We have FIT, and actually FIT is quite difficult to beat. FIT has a sensitivity of around 80%, depends of course a lot on the threshold. When you say there's that much hemoglobin in the stool, we think a colonoscopy is indicated. You can play with that cutoff level, but it could be around 80% and specificity around 95%. So it's relatively good test and very cheap and easy to perform at home and send it. So for a competitive new test that indeed could be a bit more specific and sensitive, probably the costs are going to be so much higher. Or for example, there's a Colorectal test that's on the market in the US, where you have to send in your whole stool instead of a small sample, which is already burdensome in itself. And the test costs $500. So whereas the FIT, including the sending and the testing, usually averages around 10 to 20 pounds or so. So it's very cheap. So for any test to beat that, it's going to be very difficult.
I mean, we're talking about screening colorectal cancer. The reality is that patients, the general population, they feel embarrassed, they feel timid. There's all the issues around bowels and stool. Very difficult to see that the uptake for screening, sending a whole stool in for analysis,
the whole
is going to have any
is
sort
horrible,
of uptake.
but even a small sample for some populations or for some countries might be burdensome as well. So indeed, I think in that sense, the development of blood tests or breath tests are really interesting as well. On the other hand, when you have a blood test, you have to go to a lab to have it done. Although, of course, there's being worked also on techniques to take your blood sample at home yourself. So there's always developments also there. But any non-invasive test, I think, would be great for again, uptake reasons. And again, as you questioned me before, also to try to include people from different socioeconomic classes, backgrounds, ethnic minorities, to try to approach everyone equal, I think is really important when you try to have an effect from population screening, also for ethical reasons.
Fantastic. Well, we're pretty much nearly at the end. Evelien, fantastic discussion. What would be your take-home observations or wishes, hopes, based on the Nordic study and colonoscopy screening in general?
Well, of course, as an endoscopist, I would like my colonoscopy to be as effective as possible. So, of course, I hope in the end, after 15 years, and per protocol analysis, will be definitely having better results than we have at the moment, of course. But for screening a population, I think such an invasive test with such variable participation rates is, in my view, not the way to go. So we should definitely support the development of further non-invasive tests to make sure we keep our capacity and all our quality work for those that need it most, and we can put effort in that. Fantastic.
Great, been such fun, so interesting discussion, getting your expertise. Where time is pretty much up. I would just say that for those who have a passion for all things endoscopy, we're delighted that Evelien Dekker will be joining us for London Live Endoscopy in 7th and 8th of December. Won't just be colonoscopy, it'll be all range of diagnostic and interventional endoscopy. So it will be great to have you there. And Evelien, once again, fantastic insights, and really great to have you with us. So
I look forward to come to London.
Yeah, fantastic. Cheers. We might have 9 new prime ministers by then.
Yes, indeed.